So, hypertension, also known as elevated blood pressure, is a long-term medical condition in which the blood pressure in the arteries is persistently elevated. Now, pay attention to this word sustained or persistent. So, normally the blood pressure can go up and down, and that can cause no problem, but it is the persistently elevated blood pressures which paves the way for mishaps like severe cardiovascular disease and other consequences such as stroke, heart failure, atrial fibrillation, peripheral arterial disease, vision loss, kidney disease, and also dementia. Now, this sustained blood pressure is going to be when it is greater than 139 millimeter of mercury systolic and greater than 89 millimeter of mercury diastolic blood pressures. Then we call it clinically significant hypertension. Now, hypertension can be of two types. It can be systemic or pulmonary. Now, usually when we talk about hypertension, we usually mean the systemic one. But the pulmonary hypertension is also an important disease, and in this case what will happen is that we usually know that the right side of the heart does not have to work that hard, right? Because the pressures in the pulmonary circulation normally are 25 by 100 millimeters of mercury. This is very low as compared to the normal average systemic blood pressures, which are 120 by 80 millimeters of mercury. So, when the mean pulmonary arterial pressure becomes greater than 25 millimeters of mercury, we call it pulmonary hypertension. Okay, so a quick question. What is the most common symptom of hypertension? Option A is fatigue, option B is shortness of breath, and option C is tachycardia. So whatever your answers are, tell me in the comment section below, and the right answer will be in the description along with an explanation. Okay, so let's learn something about pulmonary hypertension for a while. Now, usually the mean pulmonary arterial pressure is around 15 millimeters of mercury, but pulmonary hypertension arises when the pressure goes greater than 25 millimeters of mercury. Now, what causes this? There are many reasons for this. Now, we can have intrinsic lung disease, which will cause hypoxic vasoconstriction. Now, why does this happen? Because normally we hear that whenever there is going to be hypoxia, there is going to be vasodilation rather than vasoconstriction. But in this case, what happens is that if you remember from physiology, the pulmonary circulation is designed a bit differently in such a way that we know that normally hypoxia causes tissue vasodilation, okay? But in this case, what happens is that when the alveolus has decreased oxygen tension, what happens is that the arteries which are responsible for the gaseous exchange in this area are going to vasoconstrict. And this is because, think about it, we don't want the blood to be going around in the arteries which has no functional gaseous exchange surface. So this is a special mechanism that occurs in the pulmonary circulation only. So whenever there is going to be vasoconstriction, constriction is going to cause increased resistance in the pulmonary circulation, and increased resistance is going to cause increased blood pressure. Secondly, we can have left-sided heart failure or valvular dysfunction. Now think about this for a second, that if there is a left-sided heart failure or valvular dysfunction, and for some reason the blood cannot get out of the left side of the heart, where will it go and pool? Of course, in the pulmonary circulation. So that is going to cause increased blood volume and thus increased blood pressure. Next, we can have thromboembolism. They can be intrinsic to the pulmonary circulation, and they can come from anywhere else as well, and thus the same arterial obstruction and increased resistance is going to cause increased blood pressure. Lastly, we can have pulmonary arterial hypertension. Now this term is mainly used for a congenital defect causing this type of hypertension. Now this congenital defect is going to be a congenital left to right shunt. Okay, now a left to right shunt is going to happen whenever there is a atrial or ventricular septal defect. Now let me explain this on a separate page. What happens is that, for example, if this is the heart, this is the right side, this is the left side. If there is a defect in the atria or in the ventricles, or less commonly in the ductus arteriosus, what happens is that in all of these three cases, since the left side of the heart has greater pressures, so the blood from this side of the heart will go into this side. So whenever the left side of the heart pumps blood, less of it will go into the systemic circulation. Now this depends on the size of this septal defect, of course. So what happens? Since the blood is pumped here, the right side of the heart is connected to where? The lungs. So what will happen is that this blood will go and increase the blood volume in the pulmonary circulation. What will happen is that this increased blood pressure is going to cause damage to the pulmonary arteries and capillaries. Damage to the pulmonary arteries is going to cause fibrosis and loss of elasticity, so we cannot control the lumen diameter anymore. Also, the capillaries, what happens is that they are going to be damaged, and we can also have loss of vascular beds, and also this can lead to no blood supply to areas of the lungs, and that will lead to lung scarring. Now all of this and a number of other processes are going to further increase the blood pressure in the pulmonary circulation, which we do not want. And since the resistance, this is going to cause the increased resistance, this is also going to cause the increased resistance. So this increased resistance is going to tell the right side of the heart to pump harder. Okay, so usually we know that the right side of the heart does not have to work that hard, that the systolic blood pressure of the pulmonary circulation is about 25 millimeters and 10 is the diastolic millimeter blood pressure. This is the normal pressures against which the right side of the heart has to pump. But in this case, what will happen is that these pressures will rise, and now the right side of the heart has to work too hard to overcome these pressures in order to continue supplying the lungs. So what will happen is that this increased pressures which were previously in the left side of the heart, they are now going to shift, and this previous shunt, which was from the left to right, is going to change into a right to left shunt. This is going to happen eventually. Okay, so what will happen is that this deoxygenated blood is going to be mixed with the oxygenated blood, and this output, the cardiac output, although the cardiac output will be there, but what will happen is that this mixed blood is going to cause all the organs are going to have to tolerate hypoxia. So this eventual reversal from a left to right shunt to a right to left shunt is known as Eisenmenger syndrome. The mixing of the oxygenated and the deoxygenated blood is going to cause tissue hypoxia all over the body, and this hypoxia will also be sensed by the kidneys, and we know that what the kidneys do is they will release erythropoietin. Erythropoietin is going to increase the reticulocyte count, because it is going to think that maybe there is some problem with the RBCs, as if there are not enough RBCs. So they are going to increase the RBCs by increasing the reticulocyte count, which are premature RBCs, and they will be released in large amounts in the circulation. And already we have RBCs in normal amounts, because that is not the problem. So what will happen is that reticulocytes, as they are immature, they are not that elastic. And what will happen is that they are going to get stuck in the capillary beds, and we are going to lose capillary beds because they're going to get stuck, and there is going to be no supply to these and the tissues around it as well. So the consequences of Eisenmenger syndrome will include thrombosis, because we have increased retic and RBC count. We can also have hyperviscosity syndrome because of the same reasons. And lastly, we are also going to have bleeding mainly in the lungs, and the patient can cough up blood, and also bleeding in other areas is also common. Okay, so that was all about Eisenmenger syndrome. Coming back to pulmonary hypertension, we can see that if the hypertension lasts, what can happen is that it can result in pulmonary edema and also right sided heart failure. Pulmonary edema because of the increased pressures in the pulmonary circulation, leading to fluid exudation, and right sided heart failure if the heart fails to withstand the hypertension. Now, we can also classify hypertension as being benign or malignant. Now, hypertension is something that isn't benign, of course, but this is something, the benign hypertension is the hypertension which is usually clinically silent, and it will cause vessel damage and other complications, but that would be over a long period of time. And it is going to be a mild or moderate elevation in the blood pressures. Now, the malignant hypertensions, malignant is a sudden extreme rise in blood pressure, and it will result in end organ damage. That is an important thing to note. Now, malignant hypertension can be de novo, occurring out of nowhere, or it can arise from the benign pre-existing hypertension, and these are mainly above the values of 200 millimeters of mercury systolic and 120 millimeters of mercury diastolic. So such high pressures are going to cause end organ damage. Now, what is end organ damage? End organ damage is a damage that occurs in the major organs that are fed by the circulatory system due to uncontrolled hypertension. End organ damage also occurs due to other reasons such as shock, but here we'll discuss the end organ damage that is due to hypertension. Now, what will the heart suffer? The heart will undergo left ventricular hypertrophy, and if it fails, it can have left ventricular failure. The brain is going to have hypertensive encephalopathy and cerebrovascular accidents, stroke, subarachnoid hemorrhages, confusion, seizures, etc. Kidney can have albuminuria and proteinuria because of the increased pressures. There can be decreased renal function, renal failure, glomerulonephritis. All of these are end organ damages. In the eye, we can have hypertensive retinopathy, retinal papilledema, and blindness, while in the periphery, in the peripheral arteries, we're going to have peripheral arterial disease and chronic lower limb ischemia. These are also all going to be the results of malignant hypertension. We can also classify hypertension as being primary or secondary. Now, primary hypertension is usually non-specific. The reason is not known. It's not that there is no reason, but the reason is basically a mixture or a combination of many factors which you cannot just put your finger on, and what happens is that in the end we do not have a real cause to link it to the hypertension, but we know that there is something wrong. So these non-specific causes can be lifestyle, a bad lifestyle, genetic factors. They can be high salt diet, alcohol, obesity, stress, etc. Now, in secondary hypertension, we have an identifiable cause. So in this case, we're going to know what is causing the hypertension. This can be kidney disease, endocrine dysfunction, birth control pills, etc. So that was a very long introduction and classification of hypertension. Now we are going to see what normal blood pressure regulation looks like. So the blood pressure is mainly determined by the cardiac output and the total peripheral resistance. So when both of these go down, blood pressure goes down. When both of them go up, blood pressure goes up. So the total peripheral resistance simply means all the resistance with which the left side of the heart or the right side of the heart, say, is going to pump against. So whenever there is going to be vasodilation, the total peripheral resistance is going to go down. And when does that happen? When there is chemicals like nitric oxide, prostacyclins, kinins, atrial natriuretic peptide, all of these are going to cause vasodilation, okay? While neural factors such as beta adrenergic factors, when they're decreased, we're going to have decreased total peripheral resistance. Local hypoxia and acidosis also cause vasodilation. Secondly, decreased cardiac output is caused by decreased blood volume, increased atrial natriuretic peptides, because whenever there is the right atrium feels like the blood volume is too much, this is released atrial natriuretic peptide. And natriuretic means that it is going to go act on the kidneys and cause sodium excretion, and thus water will also be eliminated and the blood pressure will come to normal because of normal blood volume. Cardiac output is also dependent upon the heart rate and contractility. Increased cardiac output will be increased heart rate, increased contraction, increased blood volume, and increased aldosterone, because we know that aldosterone causes sodium reabsorption and thus water reabsorption, causing increased blood volume. Next, increased total peripheral resistance is going to occur when there is vasoconstriction, right? So vasoconstriction occurs when there is increased angiotensin 2, increased catecholamines, increased endothelin, increased neural factors such as alpha 1, which are in the arteries, causing vasoconstriction, and increased local blood flow also causes vasoconstriction. Now, one thing to remember is that sodium homeostasis is key in blood pressure regulation. This is the system of renin, angiotensin, aldosterone system. I'm sure everyone knows about that. And just as a recap, renin is released by the kidney in response to low blood pressure, which through a system of sequence of events is eventually converted into angiotensin 2, and this is going to have many functions such as vasoconstriction, sodium reabsorption, stimulation of thirst center, and sympathetic activation, all in a way that the blood pressure is increased. Now let's see the pathogenesis. This is not specifically pathogenesis, but these are more like etiologies. As we talked about first, essential hypertension is going to be the 90 to 95% of the cases of hypertension. So in this case, we do not exactly know what is causing the hypertension, but there is hypertension. It can be idiopathic, which can be linked to lifestyle, obesity, smoking, alcohol, high salt diet, as I spoke of before, and it can also be a cumulative effect of environmental factors, genetic polymorphisms, and single gene disorders. Now, these disorders can be mutations in aldosterone synthesis pathway leading to increased aldosterone synthesis. They can also be mutations in the renal epithelial sodium channel proteins, which will cause increased sodium reabsorption and thus high blood pressure. This is known as Liddle syndrome. Now, the secondary hypertension is 5% of the cases, and in this case, we know what the hypertension is caused by. It can be an intrinsic renal disease such as acute glomerulonephritis, polycystic disease. There can be a renin-producing tumor inside the kidney. There can be renal artery stenosis, in which the kidney thinks that the overall blood pressure is low because the kidney itself is receiving less blood and thus release renin and all that that follows. And there can be vascular malformations like aortic coarctation. There can be polyarteritis nodosa or other vasculitides, and there can also be neurologic disorders such as, it can be psychogenic mostly, it can be increased intracranial pressure, sleep apnea. There can also be endocrine abnormalities in which the adrenocortical hyperfunction can be a cause, exogenous hormone production can be a cause, pheochromocytoma, etc. And the birth control pills, we also know that they are going to cause increased blood pressure, including pregnancy and oral contraceptives. So lastly, we're going to see the effects of hypertension, or the consequences or the complications that hypertension causes. So we know that hypertension is raised blood pressure within the blood vessels, and we know that the innermost layer of the blood vessels is the intima. So what can happen is that there can be a lot of vascular changes due to the turbulent and high flow of the high pressure flow of the blood, and it has been linked strongly to atherosclerosis. There has also been evidence that the atherosclerosis is then going to potentiate aortic dissection, and aortic dissection is such that within the proximal 10 centimeter of the aorta, I guess, ascending aorta, what happens is that due to high pressures with which the heart has to pump, what happens is that the blood, this is the lumen, this is where it should be flowing, but what happens is that it tears the intima and starts flowing in between the intima and adventitia, or intima and media. This is known as aortic dissection. And if this aortic dissection happens too near the heart, it can go back and enter the pericardium and pool there and thus cause external pressure on the heart and not let the heart pump. This is a very important complication of atherosclerosis and hypertension. Next, we can also have arteriolosclerosis, which has also been strongly linked to hypertension, which can be of two types, hyaline and hyperplastic. Hyaline arteriolosclerosis is simply that due to high blood pressures, what happens is that the plasma proteins are going to leak into the blood vessel wall, and microscopically we can see it as a pink hyaline arteriolar wall. So that's why it's called hyaline arteriolosclerosis. And lastly, we can have hyperplastic arteriolosclerosis, which is actually an adaptation to the high blood pressure. This usually happens in malignant hypertension, and what happens is that the artery is going to have concentric laminated onion skin like thickenings with reduplicated basement membranes and smooth muscles. So remember this onion skin appearance in case of hyperplastic arteriolosclerosis, and all of this is going to cause necrotizing arteritis, which is simply vessel wall inflammation, which is bound to happen when all of this is happening. Come on. Okay, and lastly, we are going to have cerebrovascular hemorrhages and intracerebral bleeds because of the high blood pressures. So that's all about hypertension. See you in the next video.